Okay. So, hi everyone. Welcome to the 107th Stanford Med AI Group Exchange Sessions. This week we have Emma Chen from Howard University here with us to talk about all their multimodal benchmarks for emergency care. Emma is a second year PhD student in the Department of Computer Science at Harvard University, and she's co-advised by both Professors Vijay Janappa Reddy and Pranav Rajpurkar. Her research focuses on multimodal machine learning for healthcare, and in her free time, she also writes a weekly newsletter, Dr. Penguin Weekly, with Dr. Eric Topol to share the latest important medical AI research with the community. So, Emma, thank you so much for joining us today. And I guess before we get started, do you have any preferences on how you'd like to take questions? Do you prefer them at the end, or is it okay to interrupt you?
Oh, it's okay to interrupt me anytime.
Okay, perfect. So let's try to keep this session as interactive as possible. And without further ado, let me hand it over to Emma.
Thank you, Nadita. So hi, this is Emma. And I believe everyone can see my screen, right? Okay, perfect. So today I'm going to talk about our recent development of a benchmark called MC Bench. It is a benchmark to evaluate multimodal foundation models for electronic health records in the emergency department. So before I talked about what MC Bench really is, some of you might already question, why are we creating another benchmark? So to answer that question, we've done our literature search. This is a table of the existing benchmark of of emergency room and also ICU patients. And the reason why we included ICU is because technically there are only two data sets, two benchmark that evaluate models in emergency medicine. So we included ICU because similar to emergency patients, ICU patients also go through a lot of tests and monitoring. And this actually brought up the first limitation we've noticed in the existing benchmark, which is the lack of available data modalities in the current data sets or current benchmarks. So like I said, ICU patients or emergency patients, they are in a more critical condition compared to patients in, let's say, outpatient. So they do go through a lot of tests and results. And they have a lot of results. But we noticed that not all of these modalities or data are being fully utilized by existing benchmark. For example, I mean, EHR codes is probably the most used modality. Some data sets includes free text notes. Some has intermittent vital signs recording, but none of them have ECG, PPG waveform. So the high frequency sensor data is missing from the existing data sets. But we also noticed that in addition to not fully utilizing all available data out there, a lot of these benchmarks also overly focus on evaluating models based on accuracy. And for us, we think that right now we're already in the era of foundation model. These are the models trained on massive data, multimodal data with the goals to be used for multiple downstream tasks. We should ask questions around multitask learning and multimodal analysis. So accuracy alone is not comprehensive enough to evaluate multimodal foundation models. But also in a clinical context, fairness is also very important. It's a high-stake situation. And although some benchmark does evaluate that, we just think that it's very essential to have fairness included in every benchmark. So we propose,
Emma,
yes.
can I ask a quick question here?
Yes.
When you say evaluation beyond accuracy, for example, Mimic, isn't it like up to the developer how they want to evaluate? I mean, it's not really a limitation of the data set
Yeah.
itself.
Yeah, it's not a limitation of the data sets, but for the existing benchmark, it is decided up to the developer of the benchmark to decide what to evaluate. And from our literature search, most of them do not evaluate things beyond accuracy. So the data sets themselves have infinite possibility, but the benchmark have to pick something to evaluate. And
Okay.
accuracy has always been the focus.
Okay. Thank you for clarifying.
Yeah, of course. So we proposed MC Bench to address this limitation of not fully using all the data sets and evaluating overly focused on accuracy. So we have a novel multimodal data set that we promise we'll release, and we're going to evaluate beyond accuracy. So what does the data set look like? This data set is collected from more than 100,000 patients in the emergency department of Stanford Hospital. I suddenly don't remember how many years it took, but over multiple years. And we will release it probably closer to the summer by the end of this year. We're still like going through the logistical stuff. But anyway, this is what the data set contains. First, it contains structured electronic health records. This is an example of what the structured health records looks like. It just imagine them as tables, and you have diagnosis codes, you have lab orders, codes, things like that. And then we also have free text radiology reports. This is a snippet of what the radiology reports looks like. It's fully de-identified. So you're not going to have any patient name or date, but other than that, it's still the radiology reports in free text. And then we have the continuous vital signs and waveforms. So for the continuous vital signs, there are things like heart rates, respiratory rates, heart rates, respiratory rates that are in high frequency. So I think we're still deciding how we are going to aggregate the data, because the data is very high frequency and we only have limited storage to share. So on average, we are probably going to share data that is aggregated every 1 minute for heart rates, which is already higher than the resolution is already higher than the existing data sets for continuous vital signs. And then for the waveform, we have ECG waveform, PPG waveform, and also respiratory rate waveform. So these are the 3 types of data we have. And then in terms of evaluation, we do evaluate models based on their AUPRC. And we choose AUPRC because this is a highly imbalanced data set. We have, I'm going to show you later what is the percentage of positive label we have for each clinical task we decide to do the prediction for. But this is a highly imbalanced data set. We use AUPRC. We do evaluate models' performance, but we also evaluate models' performance in terms of their monotonicity and modalities. So what does that mean? It means it asks the questions of whether adding more modalities for training will improve or actually lower the performance of a model. So it might feel counterintuitive that giving more information can hurt a model's performance, but we have seen this in past literature that sometimes training on more modalities gives lower performance. It might be harder to train a model. There is one theory that says, maybe when a model is trained on multiple modality, there exists something called modality competition, which means the model is going to, during update, the model is going to overly focus on updating a set of modalities versus the other, but then it's not optimizing on with the modalities that are more important. So these are theories in why models might have lower performance with more modalities. And I think this is still a relatively new field that people can investigate why this happened. But anyway, this is an evaluation we want to do for our benchmark. The second evaluation is robustness to missing modalities. And this is a metrics that are meaningful in the clinical context because a lot of time a modality that is used for training is not available during inference time. For example, maybe you can train a model on someone's urine test, but the next patient who comes to the hospital might never have done a urine test. So you're going to have missing modalities during inference time, and we want to know how robust a model is in terms of missing modalities. And the third one is the fairness across patient group. Like I mentioned, for medical context, it's important to know whether the model exhibit different performance in terms of different patient groups. And in our benchmark, we're going to measure this difference by using the difference in true positive rate. So we'll compare the true positive rate of a model's performance in patient group 1 versus B and see if the model's capability of identifying positive cases change depending on the patient groups. So in summary, we have a multi-model data set, novel, and then we're going to evaluate beyond accuracy. So now I'm going to talk about the clinical task we're going to ask the models to do predictions for. So we have selected 3 clinical tasks that encompass the entire time frame of an ED visit. So our first task is going to happen at the beginning, towards the beginning of an ED visit. Our second task is going to happen towards the end of an ED visit. And the third task happens after an ED visit. So what is the first task? The first task is to predict an onset of new decompensation, clinical decompensation in patients with initially normal vital signs. So these are the patients who are roomed, who go to the ED, they're roomed, they look normal, they have initial normal physiological data, but all of a sudden, they do experience unexpected clinical decompensation. And by clinical decompensation, what we mean is to satisfy one of the following. Either the patient has a very high heart rate, which is tachycardia, with heart rates more than 110, or the patients have very low blood pressure, or they have very low blood oxygen level. So these are the patients who will have, they look fine at the beginning, but then they collapse. So it will be meaningful to be able to have models to predict the likelihood of someone getting an unexpected clinical decompensation. And we decided to have 3 different prediction windows, 60 minutes, 90 minutes, and 120 minutes. So the first task is to predict clinical decompensation within 60 minutes, 90 minutes, and 120 minutes in patients with initially normal vital signs. And then for the second task, we are predicting the likelihood of a patient going to be discharged from the ED or going to be admitted to the hospital. This is a clinically useful task because if you can predict this in advance, maybe the hospital can organize the resource accordingly. And finally, the last clinical task we're predicting is after the patient leaves the ED, what is their likelihood of returning to the ED? And again, we have 3 different prediction windows. We predict revisit within 3 days, 7 days, and 14 days. And I also want to point out that all of these tasks are binary classification. It's going to be important for the baseline model, why they're binary classification. So I'm going to just foreshadow that. But before I move onto our baseline model, I just want to show quickly how unbalanced the data set is. So this is the class preference for each task, but they also serve as the baseline of the AUPRC. So if you get an AUPRC of close to the class preference, then prevalence, then models are probably predicting close to random. So the goal is the model needs to be at least better than the prevalence.
Oh, Emma? Oh,
Yes. Yes.
I think we have one question from the audience. Let's just take that first and then I'll ask you my
Yes,
question.
yes, of course. Yes.
Yes, sure. Hi, Emma. I'm
Hi.
Moswa. I'm a PhD student at UIUC,
Oh,
and
nice.
I wanted
I'm an undergrad.
I wanted to ask why you don't consider kind of, for example, like mortality rate tasks there, because mainly it's like an ICU and emergency room, so probably it might be a kind of like a relevant task to consider there too.
Yeah, no, totally. I think that's a very valid question. I think this is really just the choice of the designer. Modality is a frequently used clinical task. We didn't choose it because we just want to maintain this representative of being the 3 stages of a ED visit, like at the beginning, ends, and leaving the ED. I think mortality can probably happen throughout the visit. Like there's no strong reason why we shouldn't add a prediction for mortality. We just didn't. So I hope I answered your question. But I mean,
yeah, like
that's a valid clinical task.
yeah, like one other thing is that, for example, what happens like do you still consider the people who died while they are still monitored inside the data set, or like you drop these people out?
That is a good question. That's a good question. I don't think we dropped them, but they are definitely not going to use for example revisit and the disposition prediction. So for example, during when we do the disposition prediction, we remove proxy that can leak the information of disposition. Some of the proxy is just an order code that literally says disposition. But I think mortality is definitely one of the things we remove because you're not going to have disposition when someone die.
Okay,
yeah,
yeah,
I don't
I
think
see.
we remove the patient completely from the data sets.
All right, thank you. Yeah.
Thank you for the question.
And just, piggybacking on that question, for the revisit task, what do you do with patients who are, admitted to the hospital, right? So an ED visit can end if you're admitted to the hospital.
Oh yes, that's good. No, that doesn't count. I think when we generate the binary labels, if I remember correctly, we do not include hospital visit as ED visit. But I guess that definitely. I think ED visit and hospital visits are still different. Some of them happens, you have ED visit first and then hospital visits. But I think it's still fine to just totally exclude hospital visit, and I think that's what we did.
Oh no, I'm wondering like if you are if you're so sick that you're admitted to the hospital, right? So you're a sick patient who didn't revisit the ED, but you did not revisit the ED. It's because you were already in the hospital. It could be different from how hospitals are coding these hospital admissions, but if I work with Mayo data, it's like emergency ED visit, it can end in either you going home or you becoming an inpatient.
Right.
Right. So, there should be another class for those patients? Like how are you taking care of patients who are actually admitted to the hospital?
So is the question, so right now my patients they have already left the ED visit. Is
But
the
they've
question
left where? Like did they go home or did they go into the hospital?
So in our data sets, a person can have multiple ED visits throughout the data sets. So when we do the ED revisit prediction, these are only the group of people who are discharged from the ED. They didn't go to the hospital.
They didn't go to the hospital.
Because I remember there's a code in the discharge that says they go to the hospital.
That's like a different population. Just wanted to understand that they are.
Thank you. At first, I got confused because I thought I know some people they go to ED first, but they're actually just going to the hospital right away. But no.
Thank you for clearing that.
Thank you. Okay, so now let's talk about our very basic baseline model. We have a multimodal like GBM baseline. It's unique in one perspective, which is it is trained in a multitask learning scheme for like GBM model. And I'm going to explain how we did it with multitask learning. But remember, it's important that every task are binary classification tasks. So that makes it easier for us to achieve that learning skill. But here, I'm going to start with
actually before you start going into the actual model specifics. So for the text reports, how do you ensure that the text reports are, like, let's say for the first task, like the decompensation task, how do you ensure that the text reports are coming only from the first 15 minutes and not really the entire?
Yeah, we have a timestamp of the report. So we do have to throw away most of the report because they come in late, but there's emergency radiology reports. So those come in early. But honestly, after throwing out, for decompensation is hard because we can only have the first 15 minutes. So out of the 10,000 patient, we have to throw out so much data that at the end, we're actually playing with like 2,000 patients for this task.
So you throw out the patients themselves, or do you just like, is there a way in which you can get only like is there a way in your data set where the first 15 minutes, what part of the report is filled and then the next?
We have that too. And we throw out data on patient level, but also for the patient themselves. We mask any data that happens after the task, the time point of the prediction. Let me think why we throw out so many patients. We probably throw out patients either they don't meet. First of all, we also throw out patients with abnormal vital signs because these are supposed to be patients with initially normal vital signs. And then maybe there are patients with corrupted records or patients data that already indicates what's going to happen. Or after we throw out mask out data after 15 minutes, there's not data left. So we have to throw out those. But we do mask out things that we cannot have future data to predict what happened now. So yeah.
Got it. Yeah. I was just curious because like in my experience, the like masking out the future data was especially hard for reports because they're all together and there's no way to like say, at this timestamp I want only this portion of the text. So I was just curious.
We either throw away the whole report or we keep it. So we keep part of it. And we only have radiology reports, so we don't have like nursing report, things like that talk about the progress of the patient.
Makes sense.
So basically, you only have reports and not notes, or do you include notes as well?
Notes includes everything other than radiology report. Right? We only have radiology reports.
You only have radiology. Okay,
yeah, only have radiology reports.
Okay, makes sense.
Yeah, it's sad that we don't have imaging. Yes, so this is our baseline model. I'm gonna start with how what the input looks like for our like GBM. So here is the list of the available modalities we have. We have categorical values. We just use one-hot embedding. We have numerics values such as age. They're already numeric, so we just use them as numerics as it is. We have continuous vital sign. We actually do a linear regression to fit the trend of the vital signs and use the coefficient of the linear model as our like featured engineered features. And then for the waveform, we have two kind of features. One is engineered waveform features. For example, you can derive heart rate variability from the ECG waveform. Also things like pulse arrival time from ECG and PPG waveform. So we have these kind of engineered waveform features, but we also have a pre-trained transformer model that just generates the embeddings directly from the sensor data, from the waveform data. And then for text, we have two kind of text. We have free text radiology reports, which we use a variance of BERT embedding, but pre-trained on radiology reports to generate the text embedding. But we also have text descriptions of the EHR codes. So instead of just ICD, whatever number, they have the corresponding human readable, understandable explanation of the code. So we also embed the description of the codes themselves as part of the features.
Quick question.
Oh, yeah.
If you go back to the waveforms, could you give me some more details on how you, like, what's the transformer pre-trained on? Is it your data set that's pre-trained on, or is it like a general purpose foundation model that you use? Or
yeah, it's a general purpose. It's not pre-trained on our data sets at all. Our data sets is new, so they have access to our data. It is, I remember for the ECG, it is a transformer pre-trained on classification of static 12 lead ECGs. I don't remember what the PPG one is, but they're definitely not pre-trained on our data sets.
I see. And those are publicly available, like,
yeah.
Trained. Okay, got it. Makes sense.
And then another question about your EHR codes. So you're not using them as like codes, you're using their text descriptions. So you would treat them as text and not individual codes.
I think we have both. Oh wait, no. Yeah, for the EHR codes, we use the text description. So because it gives more information than the code itself.
Okay, so for example, a diagnosis, it will have an ICD code. You keep that code in your data, but you still use the description of that code.
Yeah, exactly.
In the mounting purpose. Okay.
Yeah.
Okay.
Actually, in the data sets, I think we have both. I think the data sets have both codes and the description. Because the description is very short. It's like 3-4 words.
Yeah. And lab results, right? There would be the name of the lab and the result would be abnormal, normal, or it could be a numeric value.
The lab result is numeric.
Okay. So lab results are, I think different labs, they are reported different ways. Like sometimes they're just describing it as a category, but in your case, all of the labs are basically numerical values.
I think it depends on the lab.
Yeah,
I think it's a mix. So if it's already numerics, it's in numerics.
Yeah.
Yeah.
And then if you're using text description of lab, I'm a little confused at that because lab would have a name, but then the result is numeric, right? So is it the text description or the numeric value that you're using?
It's the text description of the lab, and then if we have the lab procedure name, and then we have the lab result. So if the result is already numeric, we use numeric, but the procedure name will be text.
Okay.
Embedding of the text.
Oh, thank you.
Yeah, so these are our inputs. And then for the multitask learning part, we were inspired by language prompting and language model. So we say, oh, why not? We just have a text description of the task we want to predict and then use the text embedding and concatenate the text embedding of our prompt with the inputs and fit it to LightGBM. because everything is a binary classification task, this way we can train all the tasks, all 7 tasks together. We have like three clinical prediction, but they 2 of them have 3 windows, so we have 7 different tasks, and we train all of them together. The models we don't need to do any modification. The model doesn't need to have different prediction head for different tasks because it just predicts a binary. It just predicts a binary label. And to distinguish, to know what the label is predicted for, we can know it from the prompt. So this is how everything come together for our LightGBM model. We concatenate all the modality, the embeddings of all the modalities, as well as a text embedding of the prompt. So this is a very basic baseline model. And here's the result of the very basic baseline model. The first one is monotonicity in modalities. So I'm going to explain what the graph looks like. So in this experiment, we add modality accumulatively, one modality at a time. So from left to right, the first column of points here, they are the model's performance when it's only trained on categorical and numeric data. And the second columns of points are the performance when the models is trained on both categorical and numerics plus diagnosis data. And then the third column is model trained on categorical, diagnosis, medications. So we keep accumulating modalities until the very last column, the model is trained on all available data. So the main takeaway of this graph, and also yellows on the top are the performance of disposition task. Reds is performance for decompensation, and blues are the performance for revisit. And the main takeaway of this graph is that with our very basic baseline model, it shows an example of how model performance can be worse when it's adding more modalities. So here for decompensation, the model has worse performance when you add radiology reports, medication orders, and lab data. And this actually is consistent with a previous study that they focus on building a model for decompensation prediction. And they also noticed the phenomenon.
Emma, for the decompensation task, like I'm assuming you're limiting yourself to use only like the very initial part of the data, right? The patient comes into the ED, and I think the first 15 minutes or so you're collecting data. And that's where you see that modality competition phenomena that you're talking about. So do you think it is connected with data sparsity? I mean, you have more modality, but per modality, you have smaller amount of data. Just because like you're looking at only the first 15 minutes.
So this is a little bit like dimension curse, really, kind of. Because
dimensionality curse with like smaller data. But it's I don't think it's very straightforward to imagine, because these are not instances that you don't have fewer instances. It's just that per modality you have smaller amount of information.
But it didn't explain why adding, I guess, okay, so this is, I think it's totally possible that with more feature, that might be a dimension curse here. But a tricky thing is the modality the performance did come back when we continue adding monitoring and waveform to the data set. However, I see a problem here because honestly, monitoring and waveform data are just very crucial to the compensation. So a better way to test the hypothesis is to have monitoring and waveform data at the beginning. Not to add it so low. But we didn't test out all possible combination We've
Yeah,
only
that was my next question. How did you decide this order?
Yeah, I don't remember how we design decided to have this order, but we totally did not exhaust all possible combination. But what we have here is just to prove one wrong. Like in logic, I just this one example already show that it is possible to have lower performance with more modalities.
Yes. Because some of these modalities, they might be, correlated, right? So it makes sense that um, orders, I'm assuming it's the lab order or the radiology exam order, right? So if you're
Yeah.
adding order, you already know what labs were performed, right? So, and I think in some of the studies, it was noted that just knowing that what lab was performed is actually more informative than actually knowing the result of that lab. Uh, so first adding order and then lab, okay, lab is not really adding more information. Uh, but if you reverse it, maybe you'll see a similar trend. If you add lab and then order, doesn't really improve any performance further.
But I guess maybe we can also argue that a well-designed model should not lower the performance. It should at least not getting better. But I mean, I should.
Yes, ideally it should, if it is useless, then it should learn to ignore it.
Yeah.
Ideally
Or
it should do
filter out
that.
the noise.
I'm just wondering, like, if it's not doing that because there's just too many different modalities and not enough data for it to learn. But it's just a guess.
No, I mean, this is definitely the direction for future research to develop a better model that doesn't drop the performance. To beat our very basic baseline model. I'm sure people can beat it. It's just too simplistic.
But these are very interesting results. Thanks for sharing.
Yeah, I mean that's a surprising result because it's kind of counterintuitive, right? You get more information, you get worse performance. So the second result is robustness to missing modality. So in this experiment, the model is trained on all data, and we dropped only one modality during inference time. So looking at the graph, the first columns the model's performance trained on modalities, and during inference, all modalities are available. The second columns are model trained on all modalities, but during inference time, categorical data is missing. The third column is model trained on all modalities, but only the diagnosis data is missing during inference time. So the main takeaway, and the color schema is the same, like yellow on the top is disposition, red is for decompensation, blue is for revisit. And the main takeaway here is that we know for different tasks, the importance of modalities are different for the same model. So for example, for disposition, missing order data is very bad, will result in worse performance. For revisit, missing categorical numerics is bad. For decompensation, missing monitoring data is bad. And the clinical indication of this result is that during deployment time, maybe it's very important for us to know what is the modality that will critically affects the model's performance, and the doctor should not use those models if you know the modality is not going to be available during inference. So the last result is our bias analysis. This is a big table. The main takeaway is that our models does display differences in its ability to identify positive cases in different subgroups. So this is also provide another opportunity for future improvement. Because we only have 15 minutes left, so I'm gonna accelerate a little. So that is the result of our very basic baseline model. But we did do an additional experiment with a language model-based model. And I noticed that I think the author already presented EHR shots a year ago in Medical AI. I really love this paper, so I highly recommend People should check out their presentation. But what this language model-based model does is, if everyone probably already noticed the problem with our very basic baseline model, not only lies in the simplicity of concatenating everything together and throwing into like GBM. A very big drawback of that model is that it cannot take into historic EHR data for patients. So the patient representations is always based on the current visit. However, with models like Climber, they train an EHR foundation model as if they're training a language model. They treat a patient's medical history like a document, and the medical events in the history as words of the document. So it's just like predicting next words for language model, they predict the next sets of clinical events defined as diagnosis, procedure, medication, blah, blah, in the patient's medical history. So this way, it's able to integrate time series, the time series aspect of the EHR data. However, we only show this model as in the appendix as an additional model because it's not a fair comparison with our baseline model. Like, we're not fair to them because Climber for now can only accept clinical codes, but we have things like monitoring waveform data that is very critical to tasks like decompensation that Climber cannot be trained on. So if you look at the result in the red box, using Climber patient representation plus light GBM is significantly worse than our baseline model. But it's not a fair comparison. So it's just not that meaningful if you only look at the decompensation task. However, something that's very interesting is if you look at the disposition and revisit result, especially for disposition, Climbers is very close to our baseline models. And during training, Climber is just so much easier to train because for light GBM, for example, you need to fit everything in memory, and we have a huge feature size. It's trained slower. It has more requirements for computing, but Climber just trained much faster because of its model architecture. So highly recommend Climber. And that's going to bring up to the last part of my presentation, which is what we think the future of multimodal medical foundation models will be. And this is just the immediate future. I don't know what happened after the immediate future. But for the immediate future, I personally think language modeling is the right approach. And here are the three models I'm aware of that does language modeling on EHR. I guess the tricky part is how do you incorporate sensor data? I've not seen any of them are able to achieve that, but maybe there are some, and if anyone knows, please share. But these are three models to check out. And the next thing is, if you remember how our very simple baseline model just simply concatenate all modalities together, and the features of each modalities are learned separately. But probably a better ways to do them is to have a unified method to train all the representation of all the features together instead of training features for modality 1, modality 2, and modality 3, and then concatenate them together. And then I think there's another thing I did not write in the slides, but I guess people need to decide if you want to do an end-to-end training or you want to train a model, get the patient representation, and then use that representation for different models. And the reason why I think there might be a trade-off is because I think reading Climber, they mentioned that their end-to-end approach did not beat the patient representation approach, but maybe with more data, end-to-end might be better. So it's, to me, it's just not clear. So this is something people can experiment with. But also for the motor model, they do time to prediction. But for example, right now I'm predicting a binary task of remission. How do I convert a time to prediction results to a binary prediction result as something that requires some kind of design? So this is why it's a trade-off, maybe something to play with end-to-end versus just training the representation and use the representation for the downstream task. So here's a summary. Summary is we have a benchmark that focus on evaluating foundation models beyond accuracy. We have a new multimodal data set that comes from more than 100,000 patients. We promise it will be released to the public. And we focus on clinically relevant prediction tasks. So these are the 3 tasks that happens at the beginning, towards the end, and after an ED visit. And finally, I just want to promote Dr. Penguins a little bit. So this is our weekly newsletter. It comes out every Thursday. We're already at week 216. So if you're interested, subscribe. We're now on Substack because it's free. But before that, if you're interested in our previous anything published before week 180 is on our old website, which is drpenguin.com. So yeah, questions.
Awesome. Thank you so much, Emma. I think this was a great talk. Yeah, I guess before we open the floor for questions, let's thank Emma for the wonderful talk with a round of virtual applause.
Thank you. It's nice to be here.
Yeah, and then the floor is open for questions if folks want to start.
I have a quick question about the evaluation metrics. So, in order to evaluate the robustness, so you use the AUPRC.
Yes.
So, yeah. So, would you explain again why you choose this metrics, which is AUPRC, for the robustness to evaluate the robustness for the multimodality?
Yes. So, first of all, there's a paper that the whole paper dedicated to explain why you should not use AUROC when you have imbalanced data sets. But I think the big picture is when you have a very small prevalence of positive class, like, which is in our case, correctly predicting positive is more important than correctly predicting negative. And AUPRC is sensitive in that aspect, but for AUROC, your result will be overly optimistic. Like you might have a very high AUROC result, but maybe the majority cases are negative, and you just correct. It's easy to rank negative cases when you have very few positive. So, but there is one paper that mathematically proved why it's better to use AUPRC. We cited it in our paper, but if you want it, I can also email you the name of the paper.
Okay, yeah, thank you. So the recap is like the AUPRC is more
sensitive.
More sensitive. I see.
Yeah.
Okay. Yeah, and could you go to the slide 21, please?
Yes.
Yeah, and for here, so continuous vital signs. So I think it was good. Yeah, could you open? Yeah, and is the outcome of the embedding model is not embedded? So is it gonna be like the numerical value for the?
Oh no. It is we feed a linear regression of the continuous vital sign because we just want to know the trends. Like is the heart rate just in general rising. So we fit a linear regression, and we use the coefficient of that linear regression model as the feature. So it is numerics because they're coefficient.
Okay, I see.
Yeah, so they're the coefficient of the trends of the vital signs, which tells us if it's in general heart rate is rising, even though it's like curvy, but in general it's rising, or in general it's decreasing.
Okay. So linear regression model was used to generate the numerical value from this continuous vital signs input. Okay.
Yeah, the
Yes.
coefficient of the linear regression.
Okay, I see. And can you go to the like 25, slide 26? I'm sorry, 26, please. Yeah.
Yes.
I just wanted to make sure if I understood correctly. Oh, I'm sorry, so 29. So it was the result of the your experiment.
Yes.
Yeah. So first result, yeah. So for here, the second was you trained the entire model and you just made an inference while just dropping was single modality for for the first one, you also train every modality, and for the inference you just cumulatively add the modality to make an inference. Is it?
Oh no. So this one we are adding modalities during training, and we add them accumulatively.
Okay, I see. So you trained by adding single modality step by step, and then did the inference with the same set of modalities.
Yeah, same sets, whatever it was trained on.
Okay, I see. Yeah, I just wanted to make sure if I understand correctly. Okay.
No, this is definitely the most confusing part in the paper.
Okay, I see. Thank you. Thank you so much.
No, thank you for the question.
If nobody else has any questions, I can ask a couple of questions about. I'm just thinking because there's one way you are evaluating everything, and the other part is just the value of having this kind of data available for any other type of modeling, right? So with that in mind, do you have like timestamps to all of your codes, for example, diagnosis, medications, orders, and do you know are there it's like up to the date or up to the exact like hours and minutes?
The resolution of the timestamp is definitely up to the day, but I believe it's even higher than that. I don't know if it's second, but I think
minutes
definitely hour or
minutes,
maybe minutes too, but definitely between days and second. Maybe second, but it's probably not that useful because it's just
seconds would not be useful. I'm assuming it is at least up to the minutes because for decompensation task you are trying to get the data from like the response. The other part is you included radiology reports but not clinical notes, right? So I mean, there's a whole debate on how ICD-CPT codes they're used for billing, so they're noisy. So if you have the actual note where some provider is noting down that you have chest pain or you have history of stroke, that is way more important. So is it because of the anonymization problems that you're not including notes, or do you have any plans of including notes?
Actually, I'm not sure
Okay.
why we excluded notes. But so the way we de-identify the radiology report is we use the Stanford PAN tool, the famous one. So I don't know if that one applies to only radiology reports or it just applies to all clinical notes. So that's the only thing I could think of. But maybe there are other reasons why they're not included in the data sets. But honestly, I don't know.
Okay. The next question was about potentially including images, but I'm assuming that's also like just up for maybe some future discussion.
Yeah, maybe I can ask the PI why.
Yes, why they're holding off on including clinical notes and images.
Maybe in the future. I guess it might be hard to get approval because even for the radiology, we've been waiting for so long because the radiology reports are supposed to be manually examined to make sure there's no
Yes, sir.
identifier. So I think including imaging might add another couple of months. But I'm not sure, to be honest.
Okay. Anyway, but I think even in the current form, the data is going to be very useful.
I have a last question about
Yes.
yeah. Could you go to the next slide, please?
Yes.
Yeah, for here, yeah. So we could conclude that these two modality, which is the categorical numerics and monitoring, could be one of the key factors that predict to make a prediction.
Yeah.
So I was wondering, I mean, it could be very open questions, but I was wondering, other than AUPRC, would it be there any other factors like that we can get why this happens? I think this is the domain of the explainable AI. So by any chance, your team have thought about to why this happened other than checking, other than using AUPRC by any chance? So for yeah,
Sorry,
yeah, you can go ahead. Yeah.
Oh no, sorry. Please, go
Yeah.
ahead.
Yeah. So I mean, for example, like in the imaging, we use the GraphCam or attention map to see why that model is doing like that. So likewise, for in this result, we could say these two, which is categorical numerics and monitoring, is good, sort of important factor for this prediction outcome using AUPRC. But I was wondering, have your team members thought about why this happened, other than by seeing other than by seeing the factors other than AUPRC. So I was wondering if there's any factor that we can explain this outcome other than AUPRC. I think I'm not sure if I explained correctly. Yeah.
No, I think it makes sense to investigate why performance drop using a different metrics. I think
Yeah, different metric. Yeah, that's what I wanted to say. Yeah.
Yeah, I think when we designed this, our goal is really to see if the performance dropped at all. We reduce modality. So we really just want to have, we only care about the performance, and we were not really trying to understand like feature importance here. This is why we chose AUPRC. And again, because AUPRC was more sensitive over AUROC, this is why we didn't use AUROC to represent the model performance. But I think you have a good point. We can, if for example in a clinical setting, if it's more important to have sensitivity, specificity, than an overall performance, then people should probably swap out AUPRC with metrics they care about. But you mentioned like GradCam. First of all, we don't have imaging, but also I think again our goal is not to understand what features are important, even though we guess that the important features that are dropped explain why models' performance get worse. But overall, we just want to know how robust a model's performance can remain, even after we drop the modalities. So I guess we're more interested in the end outcome. So we
I see. Okay, yeah. The reason why I asked was the outcome, the result from the experiment is very interesting, and I thought it was very meaningful outcome. So yeah, I was wondering if your team thought about other things as well. Yeah, thank you so much.
Of course.
Great. I guess thanks again, Emma, for the lively discussion as well, and then like lots of interesting future opportunities with your with the fact that it's it's a multimodal data set with like EHR related stuff. So definitely keeping an eye out for what you guys do in the future. So
Thank you.
we'll have the video up later this week. So I guess I'll send you the link after it's out. But thanks everyone for joining us today, and then we'll see you all next Monday at 1 p.m. again. And hopefully, Emma, you can also join us. Feel free to pass this on to other people.
Yes. Yeah, definitely gonna share. And thank you for all the questions. I was so worried that I couldn't make it through an hour.
Of course.
So yeah, I really appreciate the questions.